Hello, welcome to the 9th meeting of Association for Community Mental Health Promotion in collaboration with Psychiatry, Medicine and Primary Care section of WPA. Today, with our distinguished guests, we will be talking about lifestyle psychiatry. My name is Cenan. I'm a psychiatrist and currently working in Ege University, Izmir, Turkey. And I am one of the two moderators of today's meeting. It's a big honor and pleasure for me to share the moderation with Professor David Barron from Western University of Health Sciences. Our audience probably remembers Professor Barron from our previous meetings. And since we have a limited time today, instead of repeating Professor's amazing biography, I will pass to our presenter and discussants. Today, as a presenter, Professor Douglas Nordsey is sharing his valuable time with us, so thank you. He's a clinical professor of psychiatry and behavioral sciences at Stanford University School of Medicine, where he is the director of the Lifestyle Psychiatry Clinic and co-director of the Stanford Center on Longevity's Lifestyle Medicine Initiative. Dr. Nordsey has been practicing lifestyle medicine throughout his career, focusing on physical exercises for brain health and recovery from psychiatric disorders. He has been studying physical exercise for brain recovery and wellness among people with schizophrenia over the past decade. Dr. Nordsey's lab is studying the effects of physical exercise on psychiatric symptoms, cognition, and well-being, as well as relationships between activity level, motivation, and recovery. Dr. Nordsey is a distinguished fellow of American Psychiatric Association and a member of the American College of Psychiatry, the International Society of Sports Psychiatry, and the World Psychiatric Association section on psychiatry, medicine, and primary care. He's also launching a lifestyle psychiatry global initiative focused on healthcare delivery transformation. His most recent books, Lifestyle Psychiatry and Intervening Early in Psychosis, were published by American Psychiatric Association, published in 2019. He consults to startups developing community-based assessments and exercise intervention platforms. So, passing to our discussants, Berfin Nurkara is with us today, a fourth-year medical student at Ankara Yıldırım Beyazıt University, Faculty of Medicine. She says that she started the medical school with the desire to become a psychiatrist, and she is interested in both research and becoming a clinician. She has worked as an administrator in various student associations, and she is currently participating in some studies in the fields of neuropsychiatry, neuroimaging, and neurogenetics. And our other discussant, Asmita Mishrikar, is an incoming fourth-year medical student at Western University of Health Sciences, applying to psychiatry for residency. She is an educator focusing on mental health literacy for underserved populations, an addiction science enthusiast, a leader in student mentorship, and a community mental health advocate. She has conducted numerous research projects throughout her undergraduate and medical school career. She enjoys focusing on reducing stigma towards mental illnesses, assessing the usage of nature-based therapy in a forensic rehabilitation context, and promoting mental health education in her community. She has twice received the Helping Hands grant from the American Psychiatric Association, the Minority Medical Student Summer Mentoring Fellowship Award, and completed the addiction recovery training at the SCAFE Medical Student Fellowship in Substance Use Disorders. So, a big welcome again to our guests and our audience. Our audience will be able to ask their questions through our YouTube channel's chat function. So now I would like to give the floor to Professor David Barron. Thank you.
Well, thank you very much, and welcome to everyone. Although we all have suffered greatly from the impact of COVID and our inability to travel, one of the small shining lights has been the ability to have sessions like this where we can bring learners together from all across the globe. This would not have been possible were it not for the advances that have been made. So given all the stress that's going on in the world today, this is maybe one thing we can be thankful for, that we can get together with our learned colleagues and our friends and learn from each other. And I think there's nothing maybe more important than we can talk about other than lifestyle psychiatry, given all that's going on in the world today, the level of stress from a variety of geopolitical and health-related concerns. And we're very fortunate to have Doug Nordsey, a friend and colleague for a number of years now, who is really truly one of the world's experts in this field and can help us understand the importance of lifestyle issues, that the work we do isn't restricted to just giving pharmacologic agents or even just having patients in psychotherapy, although these are obviously very important tools in our toolbox. And what Professor Nordsey is going to share with us today is maybe one of the most important tools in that toolbox of interventions that are available to us to help our patients live happier, healthier, more productive lives, given all the world stresses. So with that introduction, I'd like to turn it over to Doug and let the audience know that we're really very interested in having this be as interactive as is possible. We're going to have our discussants have some thoughts, but we really would love to hear from the audience to make this an interactive, active learning session. Again, thanks to all of you. Thanks to Doug for sharing his expertise once again. And please take it away, Professor Nordsey.
Thanks so much, Dave. And I'll do some sort of more formal presentation for about 20, 30 minutes, something like that, and then make plenty of time for discussion. I really love the way that Dr. Barron just framed this discussion, right? That we'll focus on lifestyle medicine and psychiatry and what that means and what some of the tools are. But what's really important, I think the most important tool is the provider, right? That as a provider, as the person that a patient is coming to us trusting for help with their healthcare, that we're thinking with them about all the available tools and finding those tools that can best both fit their unique presentation and that they might benefit from. And so as important as it is for us to be experts in pharmacology and psychotherapy and make good recommendations there, it's also important that we're thoughtful about the entire range of lifestyle influences on their mental health that might also be employed. And think about yourself when you've had a health problem and you go to the doctor. Do you just want to walk away with a prescription, or do you want to also get some advice about the things that you can do, that you can take responsibility for, that can help advance your health beyond the prescription or the X-ray or whatever it's going to be. So I'm going to share my screen and just put up some slides, just for some talking points and some evidence. And again, I don't want to bury us in the slides, but this will just get us started. And I guess that's got a date from a presentation I did in January. As a background, as we've been talking about, many people experience continuing symptoms despite having expert psychiatric care and psychological care. Many people with psychiatric disorders don't have access to care easily, especially in lower and middle income countries, and where obtaining a prescription, finding a healthcare professional, who's trained in psychiatry, cost and distance can be problems. People often desire treatments that are within their control and may not continue with picking up prescriptions or going to a psychiatrist over time. Lifestyle medicine, we know, can be curative of many lifestyle-based chronic health diseases, like this is diabetes mellitus type 2 or hypertension and cardiovascular disease are my abbreviations there. And we know that people change their lifestyles, they can often return their health to normal. And we know that lifestyle factors contribute to the onset and persistence of many psychiatric disorders. And we'll go through some of the evidence about that today. So lifestyle psychiatry and lifestyle medicine includes a number of levels, right? And so what I've done here is I've organized it from the macro level down to the molecular level, right? And so we have evidence about the impact of lifestyle behaviors on the prevalence of disorders in populations, and we'll look at some evidence about sedentary time, excuse me, and its impact on the likelihood of making a suicide attempt in school children. We know that sedentary time is an independent factor that influences health beyond active time, right? So the amount of time you exercise can influence your health, but the amount of time that you're fully sedentary also has a negative influence. And of course, sedentary time is driven by, for sitting at a desk or at a device and for long periods of time. And of course, in our technology-driven world, where there's increasing levels of sedentary time. And then naturalistic lifestyle behaviors like exercise and their impact on psychiatric symptoms. So that physical exercise will influence cognitive function and energy in aging adults. And then going to the intervention level, if we do a study where we apply a lifestyle intervention, it can impact severity of psychiatric symptoms. So for example, a supervised exercise program reducing symptoms of depression in people diagnosed with MDD. At the neuroscience level, we see that brain-derived neurotrophic factor influences neuroplasticity, which obviously has an influence on learning and cognitive function, attention. And then the science of lifestyle behavior change and how we can help people through goal setting and reinforcement to go from recognizing that change in their nutrition or exercise behaviors could be helpful for their mental health to actually achieving success in that. And so these are a variety of the domains that we think about. I've been talking about physical exercise a fair amount, also mind-body practices like yoga and Tai Chi, meditation and mindfulness practice, diet and nutrition, which then gets into also the whole world of supplements and the gut microbiome, which are a whole nother elaborate areas of study, sleep and its impact on brain health, and then social engagement and relationships. And some of these things interact, right? Like team sports, where you may combine physical exercise and social engagement, or a yoga class. And of course, the experience of love and its influence on stress or other health behaviors. And so we'll just go into a few of these data points. So this is the study looking at 126,000 students across 43 countries. Finding that overall 10% had attempted suicide, but that the prevalence of suicide attempts increased with increasing sedentary leisure time during the day, so of time that isn't structured for other things. You can see that the lowest sedentary group with less than an hour a day had a 9% rate versus a 17% rate in those with the highest, over 8 hours of sedentary time per day, and with a dose-dependent increase in the odds ratio for suicide attempt of about 1.5 times greater odds that a person in the highly sedentary behaviors would make a suicide attempt relative to those with few sedentary behaviors. And then we also see that physical activity is a risk factor for developing psychosis. So in Vijay Mittal at Northwestern showed that people at ultra high risk for psychosis, so people who've had brief psychotic experiences and have risk factors such as family history, that they demonstrate a more sedentary lifestyle with markedly less physical activity, and show smaller hippocampi and smaller right parahippocampus. And in a group of 3,500 young people from Finland, they found that inactivity was a strong independent risk factor for going on to developing a diagnosis of schizophrenia, with a nearly 4 to nearly 5 times risk for developing schizophrenia in those in the lowest activity group, and those who were not participating in the social aspects as well in youth sports. And this is a large study, meta-analysis rather, of 49 studies that looked at 250,000 people, followed for almost 2 million person years, and found that the odds of developing depression were suppressed to 0.83, so 17% suppression in the odds of developing depression in people with high levels of physical activity versus those with low levels of physical activity. And again, you saw this across all age groups and across all continents with minor variations. and also whether you define depression just through a screening instrument like the PHQ-9 or through requiring meeting full syndromal criteria for major depression with no other moderators, so that this was a quite consistent finding across cultures and across definitions of merely symptoms of depression or full major depression. And then we also find that physical exercise as an intervention has an efficacy similar to sertraline for a depressed episode. In this study, which was a replication of an earlier study, this group at Duke compared supervised exercise in a laboratory versus home exercise that they trained people to do versus sertraline versus placebo for 4 months, and found that across all groups, all active treatment groups, there was about half of people in remission at 4 months, and 2/3 remain in remission after another year of follow-up, with no significant differences between the 3 active treatment groups, all of which were superior to placebo. But it was exercise and not medication that predicted staying in remission at the end of the year of follow-up, after the active interventions had been active phase had been ended, with a curvilinear association between amount of exercise and likelihood of being in remission, up to about 3 hours of exercise per week, after which it sort of topped out. So again, giving us some information about sort of how much exercise to recommend to people, and trying to help people get into that range that's really close to the guidelines for physical activity for adults. And again, oops, I went the wrong direction, excuse me. And then this study looked at people in Texas who had had a diagnosis with major depression and had already been treated for greater than 6 months with a serotonin reuptake inhibitor, and still had a Hamilton Depression Rating Score of greater than 14, so having significant depression. And they found that, and they really compared what was considered a sort of minimal level of exercise versus a full level of exercise. Those are kilowatts of energy generated on a treadmill or a bicycle. And it turned out actually that the low level exercise was not as inactive as they had hoped for as a control, but that the higher dose exercise was associated with increased rates of remission from major depression amongst men, and also in women. There was a division based on family history. So women without a family history of mental illness also responded to exercise, whereas women with a family history did not in this study. And they also found improvements in psychosocial and cognitive functioning in people who got moderate exercise versus those who got light exercise. And interestingly, in this study, positive affect after exercising, so feeling good after exercising, predicted treatment response for remission of depression. Whereas not getting an improvement in affect and having low levels of BDNF, IL-6, and low levels of cardiorespiratory fitness were associated with less response. So starting to really dig into some of the drivers of exercise response. And going to the neurobiologic level for a moment, then we see that physical exercise is associated with a whole cascade of changes in brain function that are, impact the systems that we know are involved in psychiatric disorders. So we see that endorphins and endocannabinoids increase in response to exercise, particularly anandamide, which is the corollary of CBD, which is so popular now with claims of helping with anxiety and with suppressing chronic pain. And of course, CBD is just mimicking the effect you get from anandamide, which you can produce on your own by exercising. And norepinephrine, serotonin, dopamine all increase in response to physical exercise. Again, all monoamines that we know are associated with improvement of depression and that our medications seek to increase. We see at the neurotrophic level that neurotrophins, particularly BDNF, which is brain-derived neurotrophic factor, and the other cascade of neurotrophic factors, which we'll look at in a minute, are increased in response to exercise, which increases synaptic plasticity and also neogenesis, so the generation of new or survival of new brain cells, particularly in the hippocampus, which is why you see that increase in hippocampal volume in response to exercise, which you see here. Also increased glycogen storage. So we know that skeletal muscles will store more glucose after physical exercise if they're fed afterwards. And it turns out the brain does the same thing. The astrocytes that support brain cells store more glycogen, particularly in hippocampus and frontal cortex, in response to exercise, so that you have energy stores to support brain function. And we also see that because of the proliferation of mitochondria in skeletal muscle, which leads to tighter glucose regulation, which is why exercise is an antidote for type 2 diabetes, that tighter glucose regulation also reduces the risk of cognitive decline as people age, because perturbations to high levels of glucose are somewhat brain toxic. And this is just diving in more deeply to the neurotrophic factors. Here you can see in the middle brain-derived neurotrophic factor and the other factors involved that all sort of stimulate brain health and neuronal health and fluffiness and proliferation, particularly of dendrites to form synapses. So we think of neurotrophic factors as the Miracle-Gro of the brain. Miracle-Gro is a brand of plant food in the United States. I don't know if people have heard of it in other parts of the world, but a way to stimulate brain health and growth. There are a family of proteins that, as I just mentioned, promote growth, differentiation, and maintenance of neurons, regulating plasticity, which is important for learning and memory, and stimulating those dendritic spines to proliferate, as well as energy levels in neurons. And it turns out that, again, exercise increases, particularly BDNF, which has been the focus of most studies, but the entire family of neurotrophins. And we see that the epigenetic regulation of BDNF transcription actually upregulates over time when people exercise regularly through these functions. Those of you who have studied epigenetics will be familiar with methylation of DNA and histone modifications. These are just the ways that our cells can turn on and turn off genes so that they're more active. And when we exercise, this methylation and histone modifications occur that say, hey, BDNF is important here. We need to transcribe more of it. So that person's body will increase transcription over time, over their lifetime. And there's even some chance that this might be transmitted across generations, although that has yet to be proven. But epigenetic effects can be translated across generations, and this exercise effect on BDNF is that potential, although it has yet to be established. And there's also this very interesting line of work looking at why is this? Why is it that the brain is designed to upregulate in response to physical activity and downregulate in response to sedentary behavior? And that has been traced to evolutionary steps when endurance exercise capacity was associated with cortical growth in early hominids, and the transition to a hunter-gatherer lifestyle where being able to develop spatial tracking capacity was advantageous for survival, as well as learning and retaining location of successful hunting and foraging, learning hunting strategies and social hunting strategies, so that social cognition and the ability to manage and regulate anxiety or fear and suspicion and low mood and low motivation by being able to suppress those things. Individuals were able to be more successful in this hunter and gathering lifestyle, and it supported survival. And so that's those are the hypotheses behind why we have this regulatory capacity of our brain in response to activity levels. We'll just take a quick dive down into brain anatomy. So MRI studies, This is a meta-analysis of MRI studies that Joe Firth and Rebecca Carney looked at across a number of studies that typically involved 90 minutes per week for 12 to 24 weeks of physical exercise, and showed that there's increases in gray matter volume with increased connectivity and increases in white matter volume as well in response to exercise interventions. Particularly the left hippocampus seems to be most responsive to physical exercise, and the left hemisphere globally more sensitive to exercise-induced enhancements in function. And this is one of those studies. This is Thomas Schwie, who's part of the Dutch group that's looked at physical exercise in people with schizophrenia, and found that compared to healthy controls with an hour twice a week over 6 months of supervised physical exercise, including both aerobic exercise and strength training, that increases in VO2 max, which is a measure of physical fitness, right? So those people who, as people increase their physical fitness, that was correlated with increases in gray matter volume and associated reduction in ventricular volume. So ventricular volume is the empty space, if you will, in the brain, and an increase in cortical thickness, which was associated particularly in the left frontal, temporal, and cingulate areas in patients and controls. And that's an important thing. We do know that at some level, people with schizophrenia have already developed some volume loss in association with the illness, particularly related to over pruning of synapses. And so the ability of brain-derived neurotrophic factor to increase in response to exercise and stimulate synaptic connections may to some degree reverse some of the underlying neurobiology of psychosis. But even healthy controls, in all of these studies show similar increases, sometimes larger increases in volume in relation to exercise. And so this is not just a restoration of neurodegeneration associated with disease, but also response that we see across people of all stripes. This is going over into the area of meditation, where functional imaging studies have shown functional and structural brain changes in areas involved in attention, memory formation, executive function, self-referential processes, interestingly, thinking about what happens in meditation, and suppression of the default mode network activation at rest. So default mode network is sort of your basal brain activity when you're in a MRI scanner and being asked, to just relax and not think about anything. And so it's kind of considered the background noise. And as people meditate, their default mode network activity goes down as they become more able to be in the moment and not be distracted by active thought in the background, whereas people with schizophrenia have elevated default mode network activity at rest, which is thought to be related to, intrusive thoughts and hallucinations that they can't suppress. And we also see structural changes related to meditation, particularly in the frontal polar cortex, hippocampus, anterior and mid-cingulate, and orbitofrontal cortex, as well as insula and sensory cortices, and superior longitudinal fasciculus and corpus callosum, which are involved in intrahemispheric communication. Meditation also having important effects on neuroanatomy and brain function. I know we're getting tight on time, so I don't want to take too much more time, but there's at the nutrition level, we have epidemiologic evidence that whole food diets that are more based in whole foods and de-emphasized processed foods are associated with reduced risk for multiple disorders, including depression, bipolar disorder, schizophrenia, developmental disorders, and cognitive disorders. And a diet that's high in antioxidants and healthy fats and flavonoids, such as dark chocolate, has been associated with preventing depression related to specific flavonoids in those foods. This is a study that was done by Felice Jacka in Australia, similar to the exercise study I showed you earlier, where people had been treated with, for major depression with either medication or psychotherapy, and were non-responders. This is here in the middle. And they applied a modified Mediterranean diet that focused on whole foods and limited amounts of meats, more plant-based diet. And they showed significant improvements in depressive symptoms on the MADRS, which is the Montgomery-Åsberg Depression Rating Scale, and a higher rate of remission in depression in people that were randomized to the diet versus the control group. This is 67 people with moderate to severe major depression. And the intervention was actually 7 nutritional counseling sessions versus a control condition of 7 similar sessions. So they actually weren't feeding people, they were giving them nutritional consultation. And up above here, you see there's also evidence for specific nutrients, omega-3 fatty acids, improved depressive symptoms, we've seen similar evidence with omega-3s in preventing onset of psychosis in people at early stages, but that seemed to be the impact is greatest in people who are omega-3 deficient at baseline. And so either being able to measure that or assess people's diet can help to direct some of these nutrients. Zinc may improve depressive symptoms. L-methylfolate also is actually an FDA-approved treatment for depression in people with suboptimal folate levels. And then this review paper described 5 dietary recommendations for prevention of depression, including following traditional diet patterns such as the Mediterranean that we were just talking about, Norwegian or Japanese diets, increased consumption of plant-based fruits, vegetables, legumes, whole grains, nuts, and seeds, consuming foods that are rich in omega-3 fatty acids, and limiting unhealthy or processed foods and replacing them with whole foods. And so let's shift over a bit to sort of how this works in practice, how to some of the behavior change process, and how important we as providers can be in the process of helping people to find their optimal lifestyle behaviors to support their mental health. And it really all starts with assessment, right? We want to communicate to patients the importance of lifestyle factors in what we ask them about, right? If we have an hour to do an initial evaluation with a new patient, we're going to ask them a series of questions. The things we ask are both going to inform our diagnosis and our care, but also communicate to the patient what's important. What are the things that we're asking about? So we may ask about their childhood, we may ask about trauma, we may ask about events that occurred shortly before the onset of their symptoms. But if we're also asking about their physical activity levels, their nutrition, their stress management, their relationships, we're communicating the importance of those factors, and we're also gleaning important information that's going to go into our assessment and our treatment recommendations. So what's their lifetime history? Really important, because even if a person is currently inactive, the physical exercise that they've engaged in at other times in their life may guide us in what that person has a fondness for, what they might be more likely to want to come back to if it's connected to something they've enjoyed in their early life. We want to educate them about the evidence, some of which we just looked at, about the impact of exercise and mindfulness and meditation and nutrition on brain health and brain function, make clear recommendations. And these recommendations are usually 2-part. I'll say to people, the evidence shows us that meeting physical activity guidelines of, 90 to 180 minutes a week of exercise, either 90 of vigorous or 180 of moderate exercise per week is the goal, and that's where we see the most benefit for mental health. But gee, you haven't exercised in 5 years. Let's think about sort of what makes sense as initial steps, and then how you might gradually build towards a target. So making recommendations, but also doing it in a collaborative way where we talk together about what the person feels like they can be accountable for and feels they can achieve in the interval before our next visit. Work on what's motivating for that person. Will they do best in a group setting where they're working with others to achieve an exercise goal or a nutrition goal, or to go to a yoga class? Would they do better with a single partner, or training for an event, signing up for a 5K walk in order to get themselves going? And then have a behavioral monitoring plan, which is really very similar to what I would do with monitoring medication adherence and response to medication I had prescribed with careful follow-up. And so then when the person comes back for a follow-up visit, I'm going to ask them about their adherence to the plan in a very non-judgmental way. Most often people set goals that are a little ambitious and don't achieve all of them. So many times they've just gotten around to it in the day or two before the visit because coming to see me reminded them that they had set those goals. And so maybe they've only gotten out for a walk twice and made small changes in their nutrition, but we'll still give them praise for that success. Congratulations for doing that. How did it feel? Right? And we notice any impact it may have had on core symptoms such as sadness or amotivation. We'll also look at impacts on the non-specific symptoms that we know are associated with particularly physical exercise. We know it's associated with improvements in sleep and appetite, improvements in energy and well-being. We'll look at effects on general health. And then we'll refine the plan. Okay, so here's what you did this time. Here's how it felt. What steps do you want to achieve, before we meet next time? And really engage the person in a shared decision-making process around that, so that they continue to, set goals that are realistic and progressive, and help them to, with the support of their physician or other health coach, other members of the team, can make slow, gradual progress, feel excited about it, and see the successes that they're achieving all along the way, while identifying triggers to lapse. What helps to, what things might happen that would, lead to resorting to sedentary behavior again, and longer-term goals of achievement, like, I want to be able to do this event by next year. When the first time I ran a marathon, my brother-in-law had set a goal to get sober. He had developed alcoholism, and he said, and around the time of the Boston Marathon, and he said to me, he lived in the Boston area, and he said to me, I'm going to run the marathon next year in order to help me get sober. Will you do it with me? And I said, sure. And in fact, it turned out to be successful. Of course, at the time that we talked about it, I was assuming there was at least half a chance he wouldn't stay sober and we wouldn't do it, but it worked for him, and we ended up running that marathon together to celebrate his first year of sobriety. And then finally, I want to wrap up with just thinking a little bit about where we place lifestyle interventions in care, right? And they can be used at multiple levels. Lifestyle interventions can be a first-line therapy if our assessment shows us that there's strong links between a person's behaviors and the onset of their disorder. We might say, gee, during this time that you've been, using a lot of substances or depriving yourself of sleep and become sedentary, you've developed symptoms of depression. Let's work on changing your lifestyle first before we do a medication or a psychotherapy intervention, particularly for somebody who might be very hesitant to use those therapies. It might be a preferred intervention for some people who come to us with symptoms, but also with a strong bias against pharmacotherapy. It can be part of a multimodal therapy, as we talked about at the beginning, where I might be prescribing a medication and lifestyle changes and psychotherapy. It might be a precision therapy where we see a very specific trigger to symptoms and want to develop a response to that. It could be an augmentation for treatment resistance, right? The person's already had, a trial of medications or psychotherapy and they're still having ongoing symptoms. It could be often supporting a taper, right? We often see people who've gotten into remission from an episode of depression and they're still on that SSRI and they have sexual side effects and they don't like them, or they've had weight gain and they want to be able to come off their medication, but when they taper, their symptoms start to return. And so we're using lifestyle interventions to help successfully manage their symptoms so that they can reduce their dose of medication or stop it entirely and prevent relapses. And just quickly, physician lifestyle behavior matters. Patients, for many years, I rode my bicycle to work and parked it in the corner of my office, and my patients would notice that bicycle sitting there, and it often became a part of conversation. And then, as we talked about, lifestyle changes that they could make, they felt like those recommendations were coming, from a place of genuine understanding. And lifestyle medicine and lifestyle psychiatry are increasingly important as we see data over the last 5 to 10 years, probably worsened by COVID, of increasing sedentary time associated, and social interaction transformation into online formats, increasing fast food culture that's disrupting traditional diets, and an epidemic of lifestyle-related health problems, diabetes type 2 and being overweight and hypertension, substance use, substance abuse increasing at substantial levels. Demand for mental health care, at the same time is rising dramatically, particularly amongst youth and college students. Substance use disorders are rising, and suicide rates have been rising steadily through this whole period of time that we see increases in disruptive lifestyle behaviors. So I'll just stop there, and this is just a summary of what we just talked about. I don't need to necessarily read through it all, but kind of the sequence from what we know about neurobiologic basis of psychiatric disorders to what we know about lifestyle influences and how we may be able to use lifestyle interventions to protect against brain changes and prevent illness progression, and the importance of lifestyle behaviors, lifestyle interventions at the point of encounter with patients as part of our core medical care and as part of our healthcare system. One of the things that I really find valuable about this forum in the World Psychiatric Association is to think about these things across healthcare systems, across cultures, and how the needs and interventions may vary across those. So why don't I stop there? Actually, I was going to do one more thing, if you don't mind. I was just going to, at the introduction, it was mentioned that I am part of the Stanford Lifestyle Medicine program, and that's showing you here. Let me just pick this up. So if you get a chance, this is longevity.stanford.edu/lifestyle2. This is our website and shows the work that we've been doing. And actually just back on this last page, you see the 7 pillars of lifestyle medicine, which is here. These are some of these parameters that we've just been talking about, and their influence on health, and this describes some of the work we've been doing and some of the education that we want to provide. Here's a specific item on epigenetics and the ability to reduce your epigenetic age by 2 years after 8 weeks of positive lifestyle changes. So just mentioning that quickly as well. Okay, good. Thank you all for your attention, and would love to get some discussion going and thoughts.
Well, Doug, thank you so much for that just excellent review. And it's amazing how some of the simplest things in life can be some of the most important. And just one quick comment I'm going to make, and I want to throw it over to our discussants, our students, is I don't want the audience to let by a very important point that Doug made throughout the presentation, and that's the importance of doing something that's fun. Doug and I have been involved in this area for me, it's going on 40 plus years now. But, we think of diets as something, I'm giving up something I don't want to give up. I'm giving up something I really enjoy. And I think one of the keys for me, and Doug and I have talked about this and written about this together, is that look at lifestyle psychiatry as something that makes life more fun. I know when I've done some studies, we've looked at with exercise, the first thing I ask people is, what type of things do you like to do when your body's moving that makes you feel good, that makes you feel happy? Because we are much more likely to do something that we enjoy. If you love dark chocolate, you don't have to twist someone's arm to tell them you enjoy dark chocolate over milk chocolate. So I think one of the things with lifestyle that we need to keep in mind that we all know as psychiatrists or psychiatrists to be is that if something is fun, if it brings us joy, we're much more likely to do it. And I think Doug did an outstanding job of really highlighting that. So with those comments, I'd like to throw it over to our students. Up on my screen, I have Esmita as our first discussant, and then we'll turn it over to Burfin. So Esmita, please share some comments based on Professor North's really excellent presentation.
Thank you, Dr. Barron. And thank you, Dr. Nordsey, for the amazing presentation. I was wondering, so you mentioned that exercise increases BDNF and DNA methylation and overall modifies DNA epigenetically. So to what extent are these epigenetic modifications involved in reversing neurodegeneration in conditions like Parkinson's, Huntington's, and other neurodegenerative diseases?
Very interesting question. And one of my colleagues here at Stanford, who's a neurologist, has been using dance actually as a exercise intervention for people with neurodegenerative disorders and has shown positive findings as well. So I don't know that literature as well, but they have been able to show improvements. Obviously, neurodegenerative diseases have progression to them, but they've been able to show, improvements in motor function in response to physical exercise. And they have you walk into the neurosciences building, and there's a dance studio right there on the first floor, and you see the classes happening for their patients. Good question.
Esmita, anything else before we turn it to Burfin?
No, I saw in the comment section that there is a question from YouTube. Dr. Jim Whitehead, he wants to know what would lead to the most growth globally in the effective adoption of this lifestyle approach by psychiatrists and in other medical and health settings.
This is a great question, and Jim is a good colleague, and he and I have talked about this many times. I think that because this question has a few layers to it, I would say that probably what would lead to the most growth in use of lifestyle psychiatry by recipients of healthcare is incorporating it in their care with their psychiatrist or psychologist, or with their mental health team, and that viewing lifestyle psychiatry as core to our care, rather than somebody, some other domain. Go to your yoga studio to do yoga. I'm going to talk to you about medications because I'm a psychiatrist, and I'm defining psychiatry as just medicine focused. That approach, I think really undermines holistic health and recovery, right? But Jim is really asking this at a deeper level, how do we sort of increase the adoption by psychiatrists and other medical providers? And so, I mean, I think that's part of what we're doing today, right? Is how do we incorporate, lifestyle training into medical education, into the clinical experiences that medical students and residents have during the course of their training. I think that, when I think about my life and my career, and as Dave Barron was also reflecting, I think it's, the clinical experiences you have, what's encouraged by your mentors, what you learn from your patients, and bringing yourself into it that are, what sort of leads myself and people I know who are very active in lifestyle medicine, needs them there, is sort of believing in the impact of lifestyle interventions from their own personal experience, and then having the opportunity to work in clinical settings where they could do that work with their patients and see the impact and the gratitude that patients have for that. So I think maybe the best answer to Jim's question is creating opportunities in training for people to have those experiences and have that latitude, right, to be encouraged to think with patients beyond the medical technical aspects of what we do, and into the pragmatic ways that they can help manage their health, and to include yourself in your personal experiences, and to be able to say, I know when when I have a couple of rough nights sleep, I just don't, I can't concentrate as well, and it's hard to focus, and being able to share that with people, or if I miss exercising, I just don't feel as energized during the day. That if you can share those personal experiences, people really resonate with that.
Doug, I wonder real quickly, and then I want to make sure we have time for Burfin, but what do you think about, and I've been a strong advocate of it, making this more like a public health, public policy, making sure that we make it easy to ride your bike, that we have walking paths, that at the workplace we say, every couple of hours we're going to have a 5 or 10 minute break, encouraging people to take 1 or 2 flights of stairs as opposed to the elevator. To me, I've found in California, you and I both live in California, our state takes this very seriously, not so much in other parts of the United States or the world. But I'm wondering what your quick thoughts are, and then I want to make sure we get Burfin in there to talk about taking this beyond just a treatment strategy, but really part of public health, public policy.
Yeah, couldn't agree more, and so frustrating to get into a grand, especially medical building. We just rebuilt all our hospitals in California to meet seismic standards, and then it's all elevators, and you can't find the stairs. And really, I think the more that we can encourage our communicate as healthcare systems, the focus on health and the focus on promoting health and health behaviors, and giving our healthcare professionals who are spending long hours working in our systems, those opportunities for a nap space, for the opportunity to get up and take a break from their work, instead of having a packed back-to-back schedule for an entire day, to have those breaks, to have opportunities for meetings to occur in outdoor spaces and while walking, can all stimulate creativity and effectiveness.
Great. Burfin, please. Thank you.
Okay. I was actually going to ask the same question, like how could we, can you suggest some public health strategies to incorporate physical health, physical exercise to our lives? So I will ask another question. Mm-hmm. Healthy diet is a varying concept, and it might be hard to decide what is a healthy diet. And there are some popular studies on specific diets, such as the ketogenic diet and their effect on neurodegenerative disorders or psychiatric disorders. And I want to know, what is your opinion on these specific diet studies? And do you think it is healthier to choose such restrictive diets or inclusive yet balanced ones?
Yeah, very good question. And in fact, another one of my colleagues here at Stanford has been looking at ketogenic diets in people with severe mental illness, mostly focused on helping with reversing weight gain that people have had related to their medication treatments, but also looking at the impact on symptoms. And she does, see some positive effects for mood stabilization in particular. But, that's very small literature relative to the evidence around, that we talked about here today about, more traditional diets, more plant-based foods, and foods containing omega-3s, and of course the green vegetables having high levels of B vitamins and such. So I would feel that I tend to work with my patients around more restrictive diets like intermittent fasting or ketogenic diets if their focus is weight loss, but if their focus is on improving their mental health, more of a traditional diet as opposed, and minimizing sort of processed and commercial foods. And I think that's what the evidence supports at this point.
Thank you so much.
Yeah, good question. Do you have any experiences with that yourself, Griffin, in terms of what you've seen be helpful for people?
Can you repeat, please?
I'm just wondering if you've had any experiences during your training so far where you've had a chance to work with particular types of diets with patients and seen what their experiences have been.
No, but I participated in a study, an animal study, ketogenic diets and Alzheimer's study, but it's still going on. It's an ongoing study, so I'm still wondering on the effects of this diet. So
interesting. So using a ketogenic diet in order to prevent brain decline in animals, or is it to try to reverse the effects after they've already occurred? Maybe I could ask that more clearly. Is it an animal model of dementia, or is it an animal model of aging and preventing cognitive decline?
It was an animal model of dementia.
Yeah, oh, interesting. Well, would really look forward to hearing the results. That's exciting. And, again, I think as we get more evidence about specific diets and more restricted diets and their impact on mental health, then that will help us to, be able to make better recommendations.
Yes.
Yeah, one of the things that we hear about with diets, and I think it's an important theme for this, is making sure we do this in a culturally competent way. And we've got participants from all over the world, and we know there are different tastes in different parts of the world. It's one of the reasons I love and miss traveling so much, is the tastes of different parts of the world. So I think as providers, we always want to make sure that the gold standard is actually the standard that works best. And that might change. So I think, and Doug has talked about this in his writings, and I know I've heard him give this presentation a number of times, but since we do have participants from all over the globe, it's making sure that we take into account, who are we treating? Who are we talking to? Because if I'm in Philadelphia and I tell a patient, don't eat a cheesesteak, which is a very popular food in Philadelphia, they're going to be very angry with me, as opposed to what can they do to make it healthier, to cut down the number of them. So I think lifestyle psychiatry, and me, and I know Doug has emphasized this in all of his work, is it has to be relevant to the individual where they are, both physically, emotionally, spiritually. I know Doug's talked a lot about spirituality. He didn't have time today, but in many parts of the world, hopefully all of the world, the spiritual component of this plays an important role in all of the other things. So I know we're running short on time, but any other members, Sinan, or any other members of the committee, or questions we have? This is the biggest problem that I have with these things, is we're so caught up on timeframes that we don't have enough time to get into rich discussion. But any other comments before we have to sign off? And I'm so sorry that my dear friend Boulan is having problems with his voice. I know he has important things to say, but today, and Mother Nature, I don't know, is going to allow him to speak unless he can get a few comments out.
Thank you, Professor Barron. I would like to thank Dr. Nortzi for this great presentation. My dissertation in psychiatry was about behavioral treatment of obesity. So it was a especially interesting presentation for me. I know that you have to leave for another meeting, so if we don't have any more questions, maybe we can end this meeting here. Do we have time? Some more time, Dr. Nortzi?
Yeah. Turns out that I don't have to run right away, so I can.
Okay, maybe I can ask one question then.
Yeah.
This is something I find strange since my medical student years. For example, we have a patient with obesity in any branch, in psychiatry, in internal medicine, or in any branch. The doctor says you have to do some physical exercise. You must do more physical exercise. So patients say, okay, I must do some more physical exercise. He or she goes home. Then everything goes as it was the same before that day. So I think you mentioned clear recommendations in your presentation. I think this is a very important point. I think the recommendation must be some more specific, like what will be the duration, what will be the intensity, and how many times in a week, for example. So my question is a bit related with Mr. Whitehead's question. How can we make the doctors give more specific recommendations about this physical exercise issue? And I wonder if this issue is the same in the United States with our country.
Yeah. It is for sure, Sinan, great question. And I want to address one other thing that you brought up here, which I think is so important, which is that there's so much potential for multiple benefits, right? So that if a primary care doctor is seeing somebody who has, who's overweight and has hypertension and type 2 diabetes and depression, right? That if we can identify that, physical exercise will both help with your depression and your blood pressure and your sexual function or whatever it may be, that by identifying multiple levels of potential benefit, that may help enhance people's motivation, right, for engaging. And I think that's been a key part of our collaboration with our primary care colleagues in lifestyle medicine is because they're often, trying to deal with, people's psychiatric disorders as well. Is to really identify those multiple benefits to get a person's attention. And then, as I was saying earlier, I really work, and I think a primary care physician may not have as much time and opportunity, but what I really try to train people to do is to take a few minutes to understand a person's history, what things have they enjoyed before. Maybe they were in the military and they were forced to do exercise that they hated, and sort of kind of understanding, what exercise means to them and what things they might have some joy from. And then really engaging the individual in creating a plan that they think they can do. So I really lay out for people that, yeah, I'm here and I'm encouraging you to do this. And it's easy to say yes to me in the office, but have no plan to actually do it. Let's think about what you actually might do, right? And it's going to be successful for you. Try to build it into their life as much as possible, right? Think about what time of day, et cetera. So, I'm going to start off with a high level recommendation of this is what we know helps to treat depression. And by the way, it's going to help you with your diabetes. And preventing you from developing, dementia like your parent has. But let's think about, if this is the goal you want to get to, what's realistic? What would you really be able to achieve? And then structure it as much as possible. So let's think about the time of day. And I often really think about the starting point too, because it's breaking the ice is so important, right? So I talk to people about what could let's start today. Okay. So what time of day is it? What's left? What's your schedule for the rest of the day? How could you take a 10-minute walk today just to get yourself started? Right. and really think about a very concrete first step. And then I had a patient this week, actually, who I met with yesterday, who said, you know I'm not going to get to it this week. I'll start on Friday because I wanted to, work on it over the weekend. And this is a very busy guy who, works as a computer programmer, has a very sedentary life, work life. But he was being realistic with me. I said, okay, so let's plan for Friday. What are you going to do on Friday? What time? So I think helping a person to drill down to something very specific as a starting point, set goals for themselves. And ultimately, I find that actually, people who often want to start at, 2 times a week or 3 times a week as a goal, but getting to something that's a regular part of their day, it becomes easier to remember if it's something they do every day. And it may be for health reasons that they need to change up what they're doing, but, starting each day with walking their dog outdoors, doing something that gets them active, building in routines that just become part of their day, whether that's before work, after work, at lunch hour. Another thing I work with people a lot is actually on building, and this is something that Professor Barron mentioned, building some activity into their workday can be extremely helpful for concentration and using less caffeine, right? I mean, we tend to get fatigued as the day goes on, in part because we're sitting at a desk all day long and doing the same repetitive tasks, right? And so I really encourage people to think about how they can use a lunch break, or even, get up from their desk and do, a set of sit-ups and then go back to work, as a way to just move their body and stimulate their brain and take a break from their work. And so think about ways that are really practical and they can incorporate into the, the routines of their life. So Nan, is that helpful?
Yeah, thank you for this comprehensive answer. Thank you.
Yeah.
And
if
then, you have time,
right, and then just real quickly, and then it's always an iterative process of checking back in and how did that go? And, if that didn't work, how could you modify it to make it work? Go ahead.
Yeah, the monitoring you mentioned in your presentation too, it's very important. And we have one question from YouTube. Özge asks, what is your approach to the use of nutritional supplements and superfoods?
So as I mentioned, a few nutritional supplements that have been shown to have, stronger evidence to support their efficacy in certain disorders. And so I will recommend those to people, recognizing that there's cost to nutritional supplements and helping them to think about where they could obtain them. And, again, monitoring their response similar to other aspects of lifestyle change. I don't necessarily encourage, broad, heavy use of nutritional supplements, because we do know from a lot of studies that, that the nutritional element in a pill is much less effective than coming from the food source, right? And that's been shown across all kinds of studies. So ideally, we try to think about how the person can increase their dietary intake of foods that have omega-3s and folate and other things, and then that gets into superfoods, right? And so thinking about dark chocolate and blueberries and and basically fruits that are highly colored, right, that have flavonoids in them. Dark chocolate also being a highly colored food, and so fruits and vegetables that are less white and more colored, are dense in flavonoids and other nutrients that really get beyond the vitamin A, B, C, D, and into some of the food factors that have been shown to have, strong correlation with particularly reducing risk for cancers and other health problems. I've seen less evidence about really having, other than the dark chocolate, the flavonoids in dark chocolate having a positive influence on mood and preventing depression. I have not seen other evidence for flavonoids in psychiatric disorders. We do see, as I mentioned, the folate, omega-3s. N-acetylcysteine is another interesting one. N-acetylcysteine is an amino acid that is converts to glutathione in the body, which is a very potent antioxidant, and that has shown positive benefit in people with psychosis and improving cognitive function. And so I've recommended that to a lot of people. And and usually the way I will recommend it is that there's some evidence that it can be helpful. I've rarely seen sort of night and day responses, but that it may be somewhat helpful. You got to think about the cost of obtaining it relative to the potential benefits, but that the risks are low, right? We know that taking a omega-3 supplement or an acetylcysteine supplement, most of the supplements that people might take are generally safe and well tolerated. Obviously we want to be thoughtful about, not overusing, for example, fat-soluble vitamins that can have toxic effects.
Thank you.
Sure. And anyone else jump in if you have other thoughts about that. Dr. Barron, would you add anything?
Yeah, I think the one thing, and I think you've hit it nicely, Doug, is that with supplements, there can be a downside. Some of the supplements actually have stimulants in them, so I want to really underscore the point that you made. And what I tell my patients, and my patients include a lot of elite athletes, Olympic athletes, professional athletes, is really the best way to get these things are the way Mother Nature intended them to come in. Now, if you're deficient in something, then we might want to do a supplement. But I really try to de-emphasize the role of nutritional supplements and really talk about eating, the superfoods. That's the way Mother Nature really intended them to get into our bodies. And there, as you said, there's robust data to demonstrate that it's far more effective and far more healthy. So in my experience, again, truth be told, I'm a doping control officer for the Olympics, so I'm a little bit hesitant when it comes to some supplements. But it is true that a lot of the supplements give doses that really aren't particularly healthy. So I like to get people into the habit of finding foods that they enjoy to eat that taste good, but that are actually healthy for them, and maybe avoiding some of those foods that we know, French fries, that are deep fried in fat is probably not so good. So I like to keep lifestyle psychiatry focused on lifestyle and a healthy lifestyle. And I think you did just an outstanding job in highlighting that and sharing the science behind all that, that this isn't just, well, it sounds good. No, there's good science behind this, and the science of enjoying it and doing it more really underscores all the positive effects.
Yeah, I mean, it doesn't make any sense to throw a bunch of supplements in to be healthy and then be eating, hamburgers and French fries, right? I mean, it's just, you can't sort of correct for an unhealthy diet.
Exactly. Do we have any other questions or comments? And I know I get so excited about this, and I'm hoping we have a lot of students on, because to me, for a student, it's not like learning or memorizing the dose of a particular medication or what its mechanism of action is, but it's about doing things that anybody, any grammar school child could understand, that we can present it in a way that it's good for you to go out and run around and have some fun. And for children, to say it's not about, well, you've got to go out and do sit-ups, but go out and run around and kick a ball around and have fun and dance or do whatever makes you feel good, because if it makes you feel good emotionally, it's very likely to help you physically as well. And I think, I wonder if any other comments from our student discussants here that they could share at early stages in their careers, how they can incorporate this into their practice moving forward.
Thank you, Dr. Barron. Those are all wonderful points with regards to being a medical student and incorporating lifestyle psychiatry. I know I personally have struggled with this, especially with regards to sleep, when so much is demanded of us in such little time. And then so once sleep is off, diet is off, and then exercise gets, put by the sidelines. So one of the ways that I found to be, extremely important is to incorporate a mindfulness practice, which leads to better sleep. And then that helps foster better diet, better exercise, and better academic performance. So I just wanted to thank Dr. Nordzi for, touching on that and discussing yoga and Tai Chi and mindfulness meditation, and especially its effects on gray matter development in the hippocampus. So thank you again.
Yeah, and when you present that that data to people, then it helps them to be more, more motivated to say, oh, I guess that because I treat a lot of student athletes here at Stanford who have the pressures of trying to manage all the things that you were saying, intense academic demands plus the training demands of their sport and travel for competitions and such, and so they often, are pinching their lifestyle in various ways, and helping them to recognize that, that lifestyle behaviors are going to, strengthen their brain function. I have this discussion often with people I care for who are, employed in Silicon Valley, as I was mentioning the gentleman earlier, who's, a lot of people who are involved in software and computer technology spend a lot of time sedentary, right? And often work into the late hours and deprive themselves of self-care, and helping them to, to recognize that at a physiologic level, their brain function is going to be improved. Their learning is going to be enhanced by taking good care of their brain. Kind of gets, it sinks in that's, it's worth investing in self-care in order to, invest in your brain performance, right? And taking a sort of using performance language and moving people into that way of thinking about it, often gets people's attention, right? That it isn't just about, that's something I should do, for myself. It's that actually sleeping, adequately is going to improve my brain's performance so that I can be more effective and successful.
In my own experience, I realized that physical movement is good for my health, and I try to add some sportive activities to my routine. I started taking dancing lessons for a while, and I tried boxing and all the different activities, and I realized mindfulness activities are good for me, and music is good for my health too. But when we're struggling with depression, it's hard to find that activation energy. Like, we know that physical exercise is good for us, or eating healthy is good for us, but it's hard to get up from and do it. I'm just lying in my bed, and I know that if I get up and do some exercise, I will feel better, but I can't do it. It's hard to find that activation energy sometimes.
Thank you so much for sharing that. And two things that you said I want to highlight. One sort of gets to Sanam's question before, which is what you just described as sampling, right? So you, and this is what I really encourage my patients to do. Try this, try that, see what connects for you, right? It's fine if somebody tries something and it just doesn't work for them and they don't like it, but get them to continue to keep trying things and find what sticks, right? What gives them joy, as Professor Barron said earlier. And then the other thing that I talk to people a lot is this interesting relationship between activity and energy, right? And this gets to the whole science of depression and its association with inflammation and with sort of disease behavior, right? And there's a lot of evidence that depression, that our brains are wired to have the capability for depression as sort of a response to disease, right? That the behaviors that depression encourages would be appropriate if you had the flu, right? And socially isolate and stay in bed and are inactive. And the thing is that resting only helps fatigue that is the result of overactivity. And I make this point to my patients all the time, that if you just ran a marathon and you were tired, yes, you should rest, and that will help you have more energy. But if your fatigue is not from excessive physical activity, resting makes fatigue worse, right? And activity makes fatigue better. And so getting people to turn that around, because, you know, we're just so wired to think of, I'm tired, I need to rest, right? And helping to change that cognitive connection to, and then have people try it, right? Do the sampling. And so, and as you said, then once you get active, you find that you do actually feel more energy. So that helping people to change that connection in their mind from I'm tired, I need to rest, to I'm tired, I need to be active in order to activate myself and overcome the fatigue. And so making that connection with people often can help a light bulb go off for them.
It's such an excellent point, Doug. I think people forget that if I'm tired, I should rest. But again, the reason you're tired is, I think, and people can, I think, can understand that. So, you know, it's the simple things that sometimes are the most powerful and yet the ones that we just lose sight of. And I think that's maybe our role as being a doctor. You know, let's never forget that the word doctor comes from the word docere, which doesn't mean to diagnose and it doesn't mean to treat. It means to teach. And maybe when it comes to lifestyle psychiatry, we help teach our patients and ourselves on why things are important and what drives those. So just an outstanding point. I'm so thrilled with the way this session has gone. And I just wish we could get a few more questions. How much time do we have, Sienna? I don't know if we had 90 minutes. I know Doug had some other appointments, but I don't want us to, and if we end 5 minutes early, I want everyone on the call to take those 5 minutes and move your body in a way that's fun and enjoyable. Don't go drink another cup of coffee with refined sugar in it, but at least for today, if we end 5 minutes early, we're going to spend 5 minutes, we're going to treat ourselves with that 5 minutes of health.
I can share one of Dr. Bülent Coşkun's questions if we have time, Dr. Nortzi.
Yeah, my 8 o'clock in my time meeting got canceled, but I do have an 8:30 that I'll need to go to. So just in a few minutes, but let's go ahead.
Okay. Dr. Coşkun asked about your opinions about the mental health promotion. Could you please share your thoughts about mental health promotion?
That's a pretty broad question. I'm trying to think of what they're getting at there, but so thinking about how to promote positive mental health through lifestyle activity. Well, maybe the way to think about it, I'm not sure if this is where the question is coming from, but actually we were just, talking about sort of fatigue and wearing oneself down, sort of driving ourselves, and that oftentimes, people are going for that cup of coffee because they feel tired after spending, hours and hours at a desk working on a computer, and that they, tend to think about, I need to respond to, I'm exhausted from a day of sedentary work. And so I need to, lay in front of the computer and watch more videos on YouTube and relax or watch television, or have a cup of coffee to energize myself again. And that, helping people to, recognize that, excessive amounts of time in sedentary behaviors and indirect interactions may actually, be driving poor mental health, and that part of the way that we can help to enhance mental health broadly amongst people who may have no psychiatric disorder is to help them to, recognize the importance of having a balanced life and incorporating, opportunities for for social interaction, which has been hard during COVID, and physical activity, and of course, one of the saving graces of COVID is that being outdoors is relatively safe in terms of transmission. And so, I think that there's still been lots of opportunity to to enjoy nature and be physically active. And so again, that's what I would focus on, is helping people to be thoughtful about a balanced life and the opportunity to, to manage and maintain their mental health and optimize their performance by good self-care, taking reflective time every day, taking time to step away from the being on with devices and texts and emails and all of that. Taking time for direct human connection and meditative time, and these things can be combined. Solo physical activity can be a great time for contemplative, sort of meditative experience, whereas group physical exercise or with a partner can be a nice time to also incorporate social relationship.
Thank you. So if our discussants have any questions, we can take in, or...
And I should sign off because I need to get to my next meeting at hour. So.
Okay.
Thanks, Doug. Great job.
Thank you all.
Thank
It's been a pleasure to work with you this morning and to get to know everyone. And appreciate our audience on YouTube. I hope that it's been a helpful and informative session.
Thank you very much for being with us.
Thank you for your presentation.
Yeah, my pleasure.
Have a wonderful rest of your day.